So we've got to the last session of the day, and some will say the best. We have still some great discussions coming up. This session then on digital transformation, what the future holds. And I know this is going to be a really good one. So very good to welcome back Klaus Bernke to moderate this session. Thank you.
Great. So I'd say let's kick off the session. Thank you, everyone, for joining. We'll be talking about the future of interventions. And I already told the panelists when I met with them a few weeks ago, I said, I'm going to be asking stupid questions because I don't know very much about robotic surgery. I've been in consulting for a long time, focusing on digital transformation, but have never really focused a lot on this topic, so I hope to learn a lot, and I can also ask a lot of stupid questions and hopefully get some great answers. I think we have a good mix of panelists here today coming from academia, from practical applications of the technology, and also from the corporate side, building solutions, delivering solutions for these topics. So I guess firstly, let's kick off with some introductions. And I always think it's easier if people introduce themselves than if I do it, because people are always better at knowing their own biography. So maybe let's start here, and then we'll go through the panel. So in the directions that I see everybody here, Hutan, then Michel, and then Benoit, please. Maybe Hutan, if you want to kick it off here in London.
Thank you very much, and welcome to the audience. My name is Hutan Ashrafian. I am an active surgeon. I'm a clinical lecturer at Imperial College London, and I am the lead for translational AI at the Institute of Global Health Innovation as part of Imperial College London's institute to push ahead innovation in a very big way at a global level. My experience is 20 years as a clinician scientist. I continue to practice surgery, and I have done today, and I spend time both in academia, in clinical practice, but also in entrepreneurship and running the startup world and VC world.
Thank you. So, Michel?
Yeah, thank you. And good afternoon, everyone. My name is Michel Thérin. After a brief period in academia, I am an industry executive for now over 25 years. And I have dedicated my career to develop technology to push the limit of what can be done minimally invasively. More recently, I joined Siemens Healthineers, for whom I have been leading the interventional business for a little bit over 3 years. When we are talking about interventional business for Siemens Healthineers, we are mainly talking about interventional imaging, and more recently about also robotic assistance. In my past background, I've been working for Covidien and Medtronic for quite some time, where I have also developed technology for minimally invasive many surgery. And in terms of academic background, I have a double training, both in veterinary medicine and a PhD in biomedical engineering.
Thank you. Benoit?
Hello. Thank you, and first of all, I'd like to thank you for this invitation to this panel. I'm Benoit Galix. I am a professor at SIS, working in the academia as well since more than 30 years. Starting my career in the south of France in Montpellier, then moving to Canada at McGill University, and now back to France, leading the EHU of Strasbourg, which is a research center with a specific focus on image guide therapy and invasive therapy. We are really focused on translation and innovation and a clinical outcome that we can reach in the fastest way from the research to the patient. My academic background was in interventional radiology. I am interventional radiology by training, that I still do. Unfortunately, less that time than I want, but today I did some. That's the reason in this color today.
Great, thank you very much. So let's begin with a question to kind of set the scene. What is happening in this field really today? I guess both in an inpatient and also in an outpatient setting. Can you describe some examples of what's possible today? Later on, we'll talk about a little bit where is it going, what will happen in the future, but what's possible today, and how is it really making an impact?
If I start, I'd like to say that in a clinical world, the experience with robotic surgery has been one that maybe 5 years ago was focused on a rare breed of surgeons who were particularly expert in what they did and were allowed to have access to a robot in their institution, and not all institutions had them. Today, in 2021, robotic surgery is not seen in itself as a totally different breed of surgeons who are practicing it. It is an established therapeutic modality in a surgical pathway in several specialties. It's not universal because the evidence isn't universal across all specialties, but certainly the level of education and proctoring has never been so high, and there are people who have entered some specialties where the only way they know how to do some procedures is the robotic approach. For example, robotic prostatectomy. Now, there are many different robots out there at the moment, and because of the change in patents in the past 2 years, the market's opened up, and the monopoly from one particular player has also changed, so that the exposure to a wide range of robots has become one that is tangible. That said, the evidence is yet to be demonstrated to highlight the efficacy across the board, so that there's still targeted places where robotic surgery works, for example, in pelvic and urological surgery, but it still needs to gain more evidence in different situations for an increased uptake.
So Michelle, what do you see as what's currently kind of state of the art or the most interesting application examples that you've seen?
Yeah, you were mentioning what is feasible today. I think in a vast majority of clinical disciplines, you can see now more and more procedures done minimally invasively. And that was an evolution over the last 20 years. It's a growing importance. However, in some space, because those procedures are still quite complex, the level of adoption is probably not at the level it would probably benefit the entire population. So even though, again, the limit of what can be done minimally invisively has been pushed, there are still areas where there is still some opportunity to further develop technology that enhance the usage of those minimally invasive procedures. And I think we will discuss them in the following set of questions. But it is amazing to see how more procedures are done without large incision. If you look 10 years ago, the majority of the heart valve replacement, for example, were done with an open chest. Now it's less and less the case. Same thing for aortic aneurysm, for example. Same thing for abdominal surgery. So it's amazing how those technologies have progressed and allowed less and less invasive procedures for the benefit of the patient, because that's usually associated with lower rate of complication, shorter length of stay, and reduced episode of care afterwards. But as you said, evidence needs to continue to be developed to further support those adoption. But evidence is not the only thing which is still in development. The easiness, the awareness, and the availability of those technologies still needs to progress across the world.
Thank you.
Yeah, I think my predecessor have said a lot. I will comment a little bit more about the non-robotic mini-invasive therapy that's already very well installed, and Michelle, you already comment about that. But I think the percutaneous approach in the field of oncology now became like a standard. Flexible endoscopy is also now moving to therapy in a lot of intervention. However, like you said, Michel, there is an issue in terms of learning curve and the diffusion of these techniques. Um, and we definitely need more reliable and reproducible tools to support a clinician to be more reproductive in their practice. And robotics, but not only robotics, but computer science, including deep learning approach and big database collection, may help to give very soon some support in terms of safety, in terms of learning, or presenting the good information during the intervention. I'm not speaking about 5 or 10 years. I really speak about 2, 3 years from now. Maybe I anticipate a little bit, but I think today we are missing tools to increase reliability of what surgeon does, whatever the tools they use or whatever the training they have.
I'm curious how well established is this technology today? So if I were to go into, a hospital in the UK, for example, or in France, how likely am I to encounter a robotic surgeon working on me? Is that now 80% of the time where the procedure, could be enhanced? Or is that only in 10% of the cases? What's the kind of current distribution of this technology?
It's an excellent question. And one way to answer that is to first have a clarity on what we define as robotic surgery, what we define as the distinction between robotic surgery and digital surgery, how we measure the impact of those interventions within a patient pathway. And you'll say to me, fine, well, let's come up with a definition where robotic surgery or robotic surgeon is someone who applies a robotic tool or a digital tool within an operation to enhance an outcome. And that digital tool has to have a kinematic element to it with actuators. I think that's one direction, but increasingly, as we've already heard, not all robots are the same, and not all digital surgery is the same because there are different algorithmic approaches, there are different tools, some are interventional, some are classical minimally invasive, some are modifications with a hybrid approach. But if I was to give you a straw poll, I'd say within the UK and within the US, I do not know of a tertiary level institution, healthcare institution, that doesn't have a robot of one form or another. The difference is how many secondary care institutions have a robot or not, and I'd say approximately 40 to 50%.
Okay.
So that whereas it was a super specialist exposure, for example, in cardiac centers or in particularly high volume cancer centers, it is now an established modality and increasingly so in secondary care.
Right, so as a patient, it would be useful to look for those institutions, right? Would you say that?
Well, I think we have to be very clear because there is some evidence suggesting that there is an adoption of these tools because they actually encourage patients to follow them. And I think we need to be driven by what is the highest value for our patients, and that is the best approach integrated in their pathway of care, their ecosystem of care, and then the intervention for their care. And in some cases, the evidence is outstanding for a robotic or digital approach with a machine learning overlay and diagnostic imaging approaches, hybrid guidance systems, etc. But in some cases, there are very classical minimally invasive operations that having a robotic approach might actually delay in terms of operative time and might not add any additional safety. And in those situations, one has to actually decide, is it absolutely the best thing for the patient? Is the evidence supporting this? Is it truly cost effective? I think that increasingly there are technologies that will answer all of these things across the board, but as we stand in 2021 and going to 2022, it is still not a universal, although it's slowly getting there.
Yeah. Maybe that's a good question also for Benoit and Michel to sort of see what do you see as the key benefits? Maybe starting with Benoit in your daily work of these newer technologies.
I just may answer a little bit your first question about. Oh, there is some echo. The first question about the availability of these techniques. Of course, most, I would say in France, all tertiary care hospital, academic, university hospital have this kind of facility. However, if I just take my university hospital here in Strasbourg, there is, I think, some more than 60 or 65 operating room and less than 2 rooms that are equipped with robot, general robot. That means there is a bottleneck there in terms of availability and in cost, of course, for the sustainability of the healthcare system. And one of the evolution probably is a decrease of the cost, whatever is the cost of investment or the running operational cost. That are currently one limitation in a lot of countries, including developed countries. In terms of impact, I think one probably of the most important impact is the capacity of to increase for the people, for the physicians that have been trained to manipulate robots, to increase the speed of learning curve of a new intervention. We see now some very young trainees that are very, very, I would say, easy to use this robot and can do a very complex intervention very early in their training program. Even if they are not able to do the same surgery in a, for example, open field of a usual laparoscopic approach.
To answer your question about adoption of minimally invasive surgery or intervention and the growing influence of robotic assistance in that space, it's extremely diverse by clinical disciplines and extremely diverse by continent or by countries or by healthcare system. There are spaces where minimally invasive procedures are now the routine. It will be very infrequent or improbable to see a coronary intervention done now without an endovascular procedure, which is done minimally invasively. On the contrary, if you consider a liver resection, for example, the vast majority of them are still done by open surgery. And it's not because it's not feasible minimally invasively, it's because it's too complicated, too cumbersome, too long, and too variable from clinical center to clinical centers. So this is where robotic assistance can play a growing role, because one of the big claim or the big value proposition of robotic assistance is to popularize the usage of those minimally invasive techniques. It's to make them easier, more ergonomic to be done, and more reproducible. You enhance the skill set of a population of physicians. That's basically the main claim of robotic assistance. It's not to make the procedure faster. That's also something that is often a misunderstanding. A robot will not speed you up in your procedures when you are an expert in one, but the robot will will help you to make the exact same job at 7 p.m. in the evening than at 7 a.m. in the morning. And that has a huge value in terms of reducing unwanted variation of results. So that's it's clear that there are still a lot to be done in that space. It's probably too expensive, it's too cumbersome to install sometime. Not always evidence is robust and supporting all those procedures, but it is clearly a trend, and you see that growing in multiple spaces. It started in general surgery. It now has spread in spine surgery, in endovascular surgery. It will come to almost all and every spaces in the next 5 to 10 years.
And I guess from my understanding, I think that's very, very interesting. Also, the point raised not only by you, Michel, but also by Benoit earlier, that you can train younger surgeons to do more demanding procedures. I guess I'm looking for a little bit of quantification. Does that mean like a 5-year experienced surgeon can now do procedures that would normally be reserved for someone with, say, 10 years of expertise? Is it that much of an impact? Is it more like 10, 20%?
I guess the reality is that this was never a surprise in the sense that there was a whole tribe of surgeons coming through who weren't exposed to open as much as they were exposed to minimally invasive, and adopted minimally invasive just as well, if not better, in some cases, and I mean some targeted cases, let's say laparoscopic cholecystectomy, more comfortably than they did the open operation because the exposure was more difficult. And that paradigm has kept itself into the robotic or the digital space, so that there are now, as we've already heard, people entering directly into the robotic paradigm and going back to what might call a minimally invasive approach or even an open approach would be alien to a bunch of new trainees. So it really depends on the anatomy that we're talking about and the part of the body. But I would add that whilst the anatomy is important and is the key to exposure, the whole pathway of care is still very much on the traditional pathway of traditional health and traditional approaches to surgery, such that the mindset still remains to be the open one, and we are still mimicking, in maybe 80 to 90% of cases, the open way. We are only entering the space in the past 2-3 years where we can actually now start thinking about anatomy purely through a robotic lens, rather than initially consider something open and then go to the robotic or minimally invasive. Mm-hmm. We're now in the space where we go, okay, we're talking about the heart, we're talking about the colon or the pelvis or the ovary. We can now say, if we start from the paradigm or the lens of robot, what can we now achieve? And I think that has given us some extra speed in training the next generation of trainees to come up to speed and operate faster.
That sounds very much like a culture change model as well.
It's a culture of education, but that education at the moment is still very limited to the open paradigm. And the surgical education is focused, or the robotic surgical education is focused on a particular handset or a particular platform. I think there'll be an increasing need for a fluidity of exposure here.
Mm-hmm. Mm-hmm. So I guess Benoit and Michel, do you see it the same way?
Yeah, I 100% agree with what you said, and what I see also is the generation of robots that is mainly used worldwide puts this a little bit far from the patient. And there is not so much facility to move from conventional laparoscopic to robotized laparoscopy approach. And probably new tools will be able to easier switch between one supporting tools, robotic supporting tools, to a more classical approach, or all min-invasive. That I think there is a need there. I'm not sure that having the surgeon very far and remote for the patient will fit all type of intervention, and that there is some specialty that will always need the association of classical approach. But globally, I fully agree with what you said about the training. Also, just to emphasize the fact that a new generation comes with a very good interaction with computer, including a joystick and video game tools that are very close in the way they use it when they come to use robot. And the simulation tools are just one new game for them.
Maybe another aspect of the potential benefit of having robotic assistants more broadly deployed across the world is that as soon as you put a robot in between the patient and the physician, you have a computer there. And that computer can also collect and bring a lot of information at the time when it is needed. So you can collect a lot of pre-operative information, you can collect a lot of peer-operative information, and you can start to imagine that clinical decision support can be available at the tip of the physician head and hands, and that may also help to standardize and fluidify the pathway for patients. And combined to that, you have also a growing role of imaging guidance, and the three are converging in the same kind of cockpit, where you have integrated, available anytime during the procedures, multiple 3D imaging, both pre-operative, perioperative, and all that connected and overlay on the patient image through your robotic assistant. So it's an entire new world of technology offering in the context of an operating room, far different from what it was 10, 15 years ago.
I think that's a really interesting observation, right? The fact that you now have a computer, right, at this interface between the physician and the patient. And I guess one of the questions when we're talking about culture change, right, and change of clinical paradigms is always, you know, one question that I've asked, and I spent quite a bit of time also in Australia and in Asia, and you know, where typically hospitals are, like some of them, depending on which country, where you look, Singapore, Hong Kong, for example, are quite advanced technologically. And I was always wondering, the education of a medical doctor, right, is not, or at least in, you know, many places where I've seen it, is not very technology oriented, right? It's very human oriented, which is of course the center of the profession. But of course now, since we live in a digital age, you know, obviously the earlier you can bring people into contact with technology that they will be using in a hospital setting or even an outpatient setting, the better, right? Because it forms part of that education. And even at that time, a few years ago, there was still, you know, many doctors being schooled without ever having seen a modern electronic medical record, for example, right? And then you get used to working on paper and all these sorts of things. So I see a slight parallel there as well. So if you look at kind of the education landscape and the making of a surgeon today, when do they come into contact with these technologies?
Well, I have to say that sadly, as a specialty or as a subject, we're known as having a lag period before adopting innovations, and that was typically associated with biological therapeutics. But the reality is that the ideas of digital interfaces, the idea of analytics, big data, have been in the public guise for at least 10 years. You know, in the past 5 years, AI has just been exponentially growing. So the onus has been on the medical schools to catch up very, very fast, and as a result, the surgical trainees to catch up at the same time. It has taken a little bit of time. Some of the very forward-thinking medical schools are encouraging adoption of digital technologies from day one, and the whole paradigm of surgical education is also changing, so that there is an incentive to learn digitally. There is an incentive to learn through frameworks of digital understanding rather than a classical textbook, or using 2D images is now to go 3D images, rotate, but self-learning rather than classical didactic learning. Mm-hmm. And I think surgery is following the same path. There are now 101 different tools of either apps, online platforms, video platforms where surgeons are being trained. And some of our own assessment systems are still very, very old and need to catch up. And there are a set number of units. I think the units that of the people we're talking to today are some of those units, so I don't want to be biased in my discussion with you, but that does require a fundamental culture shift that comes from the whole pathway of education right at the beginning of medical school and likely before.
Mm-hmm. Mm-hmm. Michel and Benoit, do you agree with that, or do you see some pockets where that's already changing?
What do you want?
Yeah, I think really what I foresee is in the 50s you could be trained as a surgeon after say 12 years of med school and surgery training, and practice almost the same type of surgery until you retired. Right now, the technology change the speed of of modification and modification of type of surgery and methods, and at high speed. That's is a problem. It's a problem for training all the life of the surgeon. It's a problem for evaluation of the technology because you don't have time to make proper evaluation of the outcome, and there is already a new technology that has been partially adopted and cannot be, which means that the old one is already obsolete sometime before being evaluated. Um, this I think it's true for robotic surgery or robotic assisted surgery. For digitally assisted surgery, we definitely need to sometime make a stop, even if the innovation continue to run, but in academic center, to really evaluate the outcome for patient and the cost effectiveness also, and the of this technology and yes, that's I and this is a little bit difficult because there is a pressure from industry to move always and to change.
What we can see also changing is the growing evidence of multidisciplinary skill set has to be handled by the new generation of interventionalists. It's clear now that with your scissors and your needle holder, you will not be sufficiently equipped to really address what is needed and what is done. So physicians and interventionalists in particular have to be trained and are informed and aware that they need to adopt multiple approaches, which needs multiple technological perspective associated to their practice.
Just to add to that, there is, on a positive note, there has never been a better time for industry to have the awareness that if this robotic technology and its simulation patterns and its simulation platforms were to be expanded and scaled, there is no reason that in a very high fidelity simulation setting that a very young medical student couldn't attempt and learn at doing multiple operations, so that by the time they actually qualify as a doctor 5 to 6 years later and they enter the surgical internship, they were already having done hundreds of robotic cases, whether it's abdominal, vascular, or otolaryngeal or chirurgical. I think that's a very positive note that if that technology is exposed because it's digital, it's available, with fast internet connections, these things can be done even on cloud servers. I think the opportunity for industry to lead the education system for surgeons around the world is now here, and if they want to take up that mantle, I think it can be done.
Yeah, and I can easily also see, gamification enter into that, and social and competitions and things like that.
There are little Olympiads where, in the old days of minimally invasive surgery, where you'd get little hooks and balls and get the surgeons to compete, and now you can do exactly the same, and people do because you can score them, and there's the technology that's being used to frame each step of an operation can also be used to quality score anastomoses, surgical technique, surgical time, reaction time, etc. So the opportunity is very strong now.
Yeah. So if we do look into the future with this, sort of simulation environment, where do you see the industry in, sort of 3 to 5 years? Because, as my pet saying is always, computing technology grows exponentially, which is hard for people to grasp. Now with coronavirus, it's a bit easier. People see little change at first and then a lot of change. Where do you think the biggest change will come in this field, right? Is it from the application of AI and kind of more automated, sections of the surgical process where you need kind of zero interventions in the future, or is it something else?
I mean, I will answer that question in a slightly different way, in that the technology that's come about in robotics is incrementally changing, and the benefits is not following Moore's law, as you're kind of suggesting. Actually, there are now a panoply of new robots coming out. They all have some distinctness between themselves, but in terms of the actual evidence, in terms of robust outcomes, hospital stay, operative time, transfusion rates, minimizing errors, surgical outcomes, oncological clearance, etc., are not so different from each other yet. And the technology needs to push there with the AI and with the vision, surgical vision, and the haptic feedback and the soft robotics. But what will really change the adoption and the utility is the certainty, because at the moment there's uncertainty. There are some pathways that use minimally invasive approaches. There are some pathways that use robotics approaches. And it is not clear. If there was a very strong evidence base to say that unilaterally for a particular ovarian operation, that a particular robot in a particular setting, or 2 or 3 robots in a particular setting had availability and were recommended by international guidelines, suddenly you would find that the whole pathway of care might change in terms of from the primary care physician knowing that there's a robotic pathway that needs to be adopted to the discharge approach where the enhanced recovery process is also there. And changing the pathway will change the ecosystem to allow the robots to come in. I think that would be the secret. And the funding will come through that route too.
Yeah. My feeling is the change will definitely come up with collection of data. We are collecting data, and for the first time in the story of surgical intervention, we're gonna have some record of everything that's happened during a surgery that will allow to train, to simulate, to evaluate. In my research center, we have some research program about deep learning to allow to automatically evaluate safety view that are generally used in surgery. And the computer can automatically, at the end of the intervention, make a rating of what the surgeon have done. At one point, this collection of data will lead to some degree of autonomy, probably very narrow at the beginning, but some degree of autonomy. And these 2 issues, which is collecting large amount of data and giving autonomy to robots, we will need to go like the aviation has done in the 50s, in a much more safety process in terms of cybersecurity, because that's going to be a challenge, and we see that every day in other fields, and this field will join. In terms of ethics, how the collection of these data, there probably going to be some good option in research right now, but being able to learn on the data without transferring the data. But I see the change coming here in accumulating data, allowing training, simulation, and evaluation, which is a big change in paradigm, and is going to be a big change for physicians themselves to know, like an airline pilot, they're going to be record and evaluate.
Michel, any view on your?
I can only support what has been said. I think data collection will change the way we analyze our performance, the way real-world evidence will be collected, and how they will potentially provide tools, or what is usually called clinical decision support tool, that may progressively evaluate and objectivize some decision and some practice, and that will the tools. The technology is there. It's more about making all the regulation and the safety associated to those tools conform to all the different expectation across the world. That will be probably time consuming, but that's the direction. That's clearly the direction. And then again, the triptych between image guidance, robotic assistance, and data collection and data support is converging in the same kind of approach, trying to increase the precision, reduce unwanted variability, and enhance overall the capacity of healthcare system to treat more patients more reliably.
Maybe, by the way, just FYI, we have about 5 to 6 more minutes, so we're coming kind of to a close of the session, but I did want to do a quick excursion to the whole funding scheme, right? Because these are expensive machines still. And I guess, just a bit of perspective, I was talking to one of my colleagues earlier, and he said, oh, the funding situation in the US is much better, therefore the prevalence of machines is greater. And in, Germany with DRG reimbursement, even some of the consumables might be more expensive than the operating cost, the cost, the operations cost that are being reimbursed. Do you see in your various geographies that you've seen and worked at some significant differences? And do you think that more things need to change?
I think clearly there's a discrepancy which would be universally accepted, that some healthcare systems based on insurance models are very different to single-payer systems, such as if you compare US, UK, Europe to LMICs. That said, it is a major constraint in some places for the adoption of these technologies, but it can be overcome. And the route to that overcoming is if it aligns with economies of scale, change of surgical pathway, strategic change, and robust evidence and guidelines. And that means that if the right evidence is presented in the right surgical pathway and the volume outcome relations to some robotics approaches are utilizing a correct approach, then they can be taken across the world to all geographies. But there is that nuance that it needs to be accommodating all those 4 elements before they can really be universally adopted. And at the moment, because they aren't there and the evidence isn't universal and there are cost disparities, you can see that robotics has flowered in some particular places, and they tend to be either insurance-based or academic centers, for example. But the future is open for people who are incentive-minded to change the pathways of care and allow the robots to flood the system across the world.
Yeah. So I suppose maybe to hear from Michel first, because that subject's probably dear to your heart as one of the suppliers to the industry. Do you see any major change needed in the way these systems are funded? And I think Benoit made the point, right, that because of the acceleration of technology, this is impacting many areas, right, for medtech, right? The technology is becoming more powerful. The cycle times are shorter. And, you presumably need to then gather this evidence to continue to work with the payers to continue to fund these newer type of technologies, right?
Yeah, we could speak about that topic for probably a couple of hours. I mean, it's a complex one.
We have about 2 minutes left. Or
yeah. So I will try to do it in 30 seconds. I think the diversity of economical model across the healthcare systems across the world is still so variable, so diverse, that it needs some customization to each and every local condition. So for us, it's all about flexibility and adaptability to the situation. Another aspect that I would like to say in the last 15 seconds is probably from our perspective, what we also would like to overcome is the absence of treatment. I think the tool that we are talking about has the possibility to offer more access for patients who do not have access today. And we have to find the economical model which makes that possible. Again, back to the value proposition of those tools, it's to popularize, democratize, and make complex procedures easier. And we have to find the way to make it happen. That's for the benefit of the global population, and this is close to our heart, and we are working hard to make that technology cheaper and more affordable and inclusive within the different healthcare economical model that exists.
So Benoit, you mentioned earlier that you had only a few operating rooms with robots and lots of operating rooms without Without
Yes.
them, is that presumably due to funding, right?
Yeah, yeah. I'm going to take and I fully agree with Michel, but I take the counterpoint and say we should avoid the loss of treatment, but we should avoid the over treatment, especially when they are very expensive and sometimes non-useful. I think sometimes new technology has been used because they are fancy and are not really always appropriate. And I completely support the need for guidelines, for evaluation, because if not, we're going to have some non-sustainable healthcare system according to this huge price. And I think that there is a real balance between under treatment or under technology and over treatment and too much technology for something that is not necessarily need at the end of the day.
Thank you. So I think with that, we've hit the last second. And I'd really, thank you all for participating here, for being on my panel. So Houtan, thank you very much. Michel and Benoit, it's been an honor doing this with you. And, with that, I thank the audience for bearing with us here in the, late in the afternoon. And, so thank you very much.
Thank you.
It's been a pleasure.
And
Thank
goodbye
you.
to everybody.
Bye.